currently being treated for nosocomial diseases. This statistic really shocked me, and I really wanted to learn what nosocomial diseases actually were. So my topic is on the change in prevention methods for nosocomial diseases over time. So here's my table of contents, and it starts with my background and it goes all the way down to my conclusion. So what is a nosocomial disease? A nosocomial disease is a hospital-acquired infection, or an HAI, meaning it's a type of disease you would get after you're staying in a hospital. So if you're going into a hospital to be treated for cancer, a nosocomial disease would be if you got pneumonia after you were in the hospital to be treated for the cancer. Because of this, they can range in seriousness and can be found all over the body, ranging from superficial being the least serious and found on the outer layers of the skin, and systemic being the most system found in many other important organs. So one of the main ideas in my research was to learn how they changed over time, and so I did a lot of research in the history. So nosocomial diseases originally started out in the 1800s, and that was when surgery started to become very prevalent all throughout the world. This is a painting called The Gross Clinic. It was made by Thomas Eakins in 1875, and it showed how surgeries were conducted. So as you can see here, the surgeons, they wouldn't have any gloves on, and the tools were often always reused and never washed, and it was very unsanitary. When the doctors had no gloves on, they would have normal flora on their hands. And that normal flora is pretty much like bacteria that you find on the skin that is normally harmless, but when it gets into areas, for example, where the incision is being made, it can be very serious and cause infection. Also, it was all these surgeries were performed in areas like lecture hall, and when this would happen, there are many college students sitting there kind of in the background, taking notes, and there's all this bacteria, and it was very unhygienic. Because of this, it was very prevalent to have a bunch of different types of surgical infections. So, at the hospital in Edinburgh, which is located in Scotland, there is a doctor, and he named James Simpson, and he had done research on why these diseases had started to become so prevalent. So what he said was that 12 years earlier, when the hospital was first made, there were nosocomial diseases occurred in about 1 in every 8 patients in the hospital. And I thought that was a very large statistic because that's a large amount of patients in order to try to get these nosocomial diseases. But then he later said that in current day that 1 in 3 patients would actually end up having nosocomial diseases when he was working in these hospitals. So he decided that what they should try and do is make buildings out of materials that are easier to kind of try and break apart every few years, out of iron instead of things like brick, because it would be easier to get rid of and rebuild every few years. His hypothesis would help get rid of some of the nosocomial diseases because he was starting to think about hygiene. It was a start, but it wouldn't necessarily get rid of all of these surgical site infections that would occur. But even so, his idea was rejected by the majority of the scientific community and considered medical heresy, because he was doing all of his research in these buildings and in these hospitals that were made at risk, and it wasn't acceptable for him to say that we should change these buildings altogether. So nobody actually ever really got to try out his ideas. Interestingly enough, about just a few years earlier, in 1847, there was another scientist, a Hungarian scientist, Semmelweis, and what he had done research on was that maybe if people had washed their hands before the surgery was conducted, then these surgeries would have a less likely chance of infections from occurring. His idea was never actually really tested, and people considered it a crazy idea that washing hands before surgery would actually do anything. So they never tested out his hypothesis either. And later, because of all this rejection, he ended up having a nervous breakdown and spent the last of his days in a mental asylum. And so, going back forward in time just a little bit to 1888, there are many different theories and hypotheses being tested about all of these different ways to try and prevent nosocomial infections from occurring, because they have started to become very, very prevalent. So another doctor had stumbled upon Semmelweis's idea of washing hands before surgery, and said maybe this might be a good enough idea. So at the hospital that he worked in, he had half of the surgeries that were occurring, and he said that they should go and have the surgeons wash their hands before, and then for half of them would be done as normally. And what happened is this result showed that led to where we are now, where scientists do wear gloves and have like lab coats and like trying to make sure every like wear is very sterile and clean. So, this brings me to like the more attributing factors for nosocomial diseases. So one attributing factor is age. When people are nowadays who are they're normally in hospitals, it can be when they're either very young or very old. And when the patient is very young, their immune system hasn't fully developed. And when this occurs, like it's harder for them to be able to fight off on most normal diseases that the body normally can. So just a very small germ inside a hospital could end up having a very serious effect. When the patient is also very old, it also means like that their immune system has started to like break down and just become weaker. And so when their immune system has weakened, that it's more likely, like it might be a lot harder for them to fight off many different types of diseases. Another attributing factor is immunodeficiency, and that like many of you might be familiar with HIV, which is an immunodeficiency virus. And what that really does is the disease itself isn't what actually causes many of the deaths. It's the fact that like when it like kills off the immune system, many like small like different germs or like pathogens with like bacteria can come in and end up being very lethal in their own members. Another example of immunodeficiency is in a hospital when somebody has chemotherapy. And what that does is it moves all rapid moving cells. And when it does this, like, it also can kill off parts of the immune system and cause like make it more easier for a bacteria to come in and try and like attack like the body and cause death. There are other medical treatments. An example of one being clozapine, which is normally used to treat schizophrenia, and it can suppress many of the symptoms. But even so, it has many other like risk factors such as death, which can normally outweigh the beneficial factors. So this brings me to the number of deaths annually from some of the most common HAIs. Pneumonia causes the most amount of deaths, a little over 30,000 each year. Bloodstream infections cause about a little under 30,000 per year. Urinary tract infections cause a little over 10,000 deaths per year. And surgical site infections cause about 8,000 deaths per year, which is a lot less compared to in the 1800s when they were very, very frequent. This graph pretty much shows all the hospital-acquired infections, which ones are the most common. So of all of them, about 36% of all hospital-acquired infections are urinary tract infections, 20% are surgical site infections, 11% are bloodstream infections, one of the most common ones being MRSA or MRSA, and pneumonia also causes 11%, and 26% are other. What's interesting about this is that urinary tract infections are some of the most common HAI to acquire, but they cause a relatively low amount of deaths compared to a disease such as pneumonia, which is only about 11% of all HAI certified. And also just to you guys know, for all this data was acquired from medical records that were taken throughout hospitals all throughout the United States. Which brings me to central venous catheters, or CVCs. They're normally used in most hospitals, and they help transfer fluids all throughout the body. They can be very beneficial to many patients in hospitals, but they can very commonly cause CRI, or catheter-related infections. This occurs in about 50% of all patients who have CVCs. They can cause staph infections, blood infections, and urinary tract infections. And so most urinary tract infections are actually caused from CVCs, and they're, as I showed earlier, urinary tract infections cause about 36% of all HAI. So these can actually be a very leading cause of most hospital-acquired infections. There are also surgical site infections, which is ones I was talking about in the beginning about the history and how they used to be some of the most prevalent ones, but they aren't nearly as prevalent nowadays. They're caused when the normal flora of the skin, which is the bacteria, goes into areas where it's not supposed to be. And I talked about earlier how the normal flora comes from the people actually conducting the surgeries, but it can actually come from the patient themselves. So in order to try and prevent it even more so than just having gowns and gloves in a sterile environment, it's important to put antiseptic solutions or places to clean off the bacteria from the patient themselves when the surgery is about to be conducted. Even so, there might be small amounts of bacteria that do get left. So about 2% of these surgeries do end with surgery many different types of diseases, and which makes them more commonly multi-drug resistant. Because like when they treat like a bunch of like different, like completely different types of diseases, like it's easier for the disease themselves to become resistant to those drugs. So in order to try and like treat an infection very serious, like very efficiently, try and use a very specific drug. And also, like an example of a drug that has very commonly become multi-drug resistant, that most diseases have become resistant to, is penicillin. Because a lot of times it's used from like many different types of diseases, and a lot of them have built up resistance. For example, MRSA stands for methicillin-resistant Staphylococcus aureus, and meaning that it's already become resistant to penicillin. This brings me to my conclusion that there are many similar treatments for these nosocomial diseases today. So in order to try and like help be able to prevent them more and cause a smaller amount of death rates, to try and come up with newer treatments. But there are still issues with this, because every time like you make a new, let's say you have a drug now that's starting to become like that diseases aren't resistant to, but if it gets overused, it's more common for the disease to become resistant to. Then another drug might be made, but then the disease might become resistant to that, and the cycle can keep on continuing. So the prevalence, because of this, the prevalence of nosocomial diseases may go up, but it probably is very unlikely that the prevalence will be as much as it was in the 1800s. Okay, thank you. Any questions or comments?
Yes, Ms. Friday, thank you. What is the percentage of patients that enter the hospital that end up with the nosocomial disease?
Of all patients, well, about 1 in 20, so about 90%.
Okay.
Okay. Thank you, Ms. Friday. In your research, have you found any current researchers that are working on this, and any current developments?
More like treatment methods that we use, or what specifically?
Either treatment methods or prevention methods. Any further research?
Well, the most recent one was the one about like MRSA and youth and the